السلام عليكم ورحمة الله وبركاته. بسم الله. نبدأ مناقشة Assessment of fetal wellbeing in labor. Regarding the assessment of fetal well-being during labor, to start with history and examination. By history, we look for any risk factor, the gestational age, the antenatal records, if there are any abnormalities, the duration of labor, any passage of meconium. Examination, first of all general, then abdominal and pelvic assessment, looking for any possible abnormality that will affect the clinical management. The amount of color of amniotic fluid. Clear liquor of normal amount is reassuring that the fetus is in good condition. Absent liquor and the liquor that is stained with blood or meconium indicates possible abnormality. Cardiotocography. To interpret the cardiotocography, first you should look for any contractions, then you interpret the fetal heart, baseline rate, variability, accelerations and deceleration. Risk factors. First, assess if the pregnancy is high risk or low risk, because this is important to correlate the CTG reading with the clinical circumstances. In the low risk situation, intermittent auscultation either by penile stethoscope or by handheld Doppler is often advocated. Current guidelines suggesting auscultating the fetal heart every 15 minutes in the active phase of the first stage of labor, and this should be for 60 seconds following a contraction. Please don't miss this point. Is for 60 seconds following the contractions, because sometimes the abnormalities in fetal heart is not seen unless after the contraction. Here it is for 60 seconds. In order to detect the significant deceleration, maternal pulse should be recorded by palpation to avoid the confusion, particularly when fetal heart is abnormality. If we suspect fetal bradycardia, we should put the hand on the maternal pulse to know that this is the fetal and not maternal heart. Contractions. Record the number of contractions in 10-minute period. For example, we say 3 or 4 in 10 minutes. Each big square equal to 1 minute. So you look how many contractions in 10 minutes. The duration, for how long it lasts and how strong is by. You see this record here, the baseline. Cardiotocography. This is the cardiography part, and this is the toco, which means the pressure, the tocography part. Here, this is the baseline. The rise indicate uterine contraction. Put in mind that here each one square equal 1 minute. So here from this to this 10 minutes. So in this 10 minutes, we record the number of contractions. It is 1 and 2. So this is 2 contractions in 10 minutes. Regarding the fetal heart, first you look for the baseline. This is the average over 10 minutes. You see here the average baseline is about 140. The presence of variability, the rising and coming down here. This is the variability which indicate a healthy fetus. The presence of accelerations and absence of deceleration. The baseline rate over 10 minutes as the average. Ignore any acceleration and deceleration. Normal baseline between 110 to 160. Fetal tachycardia is defined as a baseline heart rate greater than 160 beats per minute. It can be caused by fetal hypoxia, chorioamnionitis if the membranes are ruptured, hyperthyroidism, fetal or maternal anemia, and fetal tachyarrhythmias. Here you see this is the baseline in 10 minutes is about 180 beats per minute, and you see with tachycardia you may have a reduced variability. Fetal bradycardia is defined as a baseline heart rate less than 110 beats per minute. Mild bradycardia between 100 and 110 is common, and may occur in post-date gestation, occipit posterior transverse position, severe prolonged bradycardia, that is to say less than 80 beats per minute for more than 3 minutes, indicates severe hypoxia. Causes of prolonged severe bradycardia: prolonged cord compression, cord prolapse, epidural and spinal anesthesia due to severe hypotension, maternal seizures, rapid fetal descent. If the cause cannot be identified and recorded, immediate delivery is recommended. Variability categorized as reassuring if it is equal or more than 5 beats per minute, and not reassuring if it is less than 5 beats per minute. Here the variability, you see upper area and lower area and the average between these two. Here 15, here 22, and here 18. So the average over these multiple records about 20. So this is normal variability. Accelerations is an abrupt increase in baseline rate of more than 15 beats per minute for more than 15 seconds. Abrupt increase over the baseline. For example, the fetal heart 130 baseline, it should reach 145. The presence of acceleration is reassuring. Non-stress test, there should be at least 2 accelerations in a 20 minutes record. Accelerations when occurring with uterine contractions is a sign of a healthy fetus. This strip, you see, first we record the baseline rate. Here it is 130. There are frequent accelerations. You see here, this is a prolonged acceleration. Here an acceleration. Look, it is 130. The acceleration reaches about more than 145, and the duration, this square, is 1 minute. This acceleration lasts for about 30 seconds. So this is significant acceleration, and here again significant acceleration, and there is no deceleration. This strip showing a normal fetal heart with normal rate. The baseline rate is about 135. The accelerations here 1, 2, 3, frequent accelerations, and the variability is normal, again no deceleration. This is a fetal cardiography. The baseline rate is about 150 initially, this is the rate. Then frequent accelerations, which indicate a normal fetus. We'll interpret this CTG. First of all, we look for contractions. There are 3 contractions in 10 minutes. Here it is about 10 minutes. You see the speed of the strip, it is 1 cm per minute. Regarding the fetal heart, the baseline over this window is 140, normal variability. There are frequent accelerations. Okay, here a prolonged acceleration, here acceleration, and no deceleration. Put in mind, these spikes not indicate deceleration. So this is a normal trace for a woman in labor. Deceleration is an abrupt decrease in baseline rate of more than 15 beats per minute for more than 15 seconds, but it should last less than 2 minutes. Okay, different types of deceleration: early, late deceleration. Early deceleration occur when the contraction begins, recover when the contractions stops. The nadir of deceleration occurs at the same time as the peak of the contraction. This is due to increased fetal intracranial pressure and decreased vagal tone. It is therefore quickly resolves once the contraction ends and intracranial pressure reduces. So this type of deceleration is physiological and not. This is the cardio and this is the tachography part. The onset of deceleration with the onset of contraction. The nadir of deceleration, which is the bottom of descent, with the peak on contraction, and the end after the end of contraction. So this is a mirror shape with the contraction. Here, these are frequent. You see contractions here, and the deceleration occur just like the mirror shape with the contraction. Okay, here again these are frequent yearly decelerations. Variable deceleration seen rapid fall in baseline rate with a variable recovery phase. They are variable in their duration and may not have any relation to uterine contraction. Most often seen during labor in patients with reduced amniotic fluid volume. So the presence of variable deceleration is an indication for amnio infusion to minimize the cord. Here, variable deceleration, it is an abrupt decline. You see here, abrupt decline, less than 30 seconds. The shape is varying and the relation to uterine contraction is varying. Okay, so this is strip of variable deceleration. Here, this is an abrupt decline, and you see this is related to contraction, this is after contraction, so this is a variable deceleration. The onset is variable in relation to uterine contraction, could be with the start, in the middle, after the end, and from the onset to nadir less than 30 seconds. Late deceleration begins at the peak of uterine contraction and recover after contraction end. Onset, nadir, and recovery of deceleration occur after the beginning, peak, and the end of contraction. This type of deceleration indicates that there is insufficient blood flow through the uterus and the placenta, and as a result there will be fetal hypoxia and acidosis, so this will cause fetal heart deceleration. Reduced uteroplacental blood flow can be seen with maternal hypotension, for example following spinal anesthesia, preeclampsia, and uterine hyperstimulation when there are frequent uterine contractions. This is the onset of late deceleration after the peak of contraction and the nadir after the end of contraction. Again, this strip, you see this is a contraction, and here until the peak of contraction there will be onset of deceleration, the nadir of deceleration after the end of contraction, and the recovery will be later on. So this is a late deceleration. Again, this is the onset after the peak. This is again late. Prolonged deceleration more than 2 minutes. If it lasts between 2 to 3 minutes, is classified as non-reassuring. If it lasts longer than 3 minutes, immediately called abnormal, and this immediate action should be taken, for example fetal blood sampling and possibly emergency section. This is a prolonged deceleration. You see the baseline 150, and then here the onset, and then a prolonged deceleration. A sinusoidal pattern, severe fetal hypoxia, severe fetal anemia, and fetal maternal hemorrhage, immediate cesarean section for this pattern, and the prognosis is, you see it is just like sign true. Okay, this is a sinusoidal pattern. This is characteristic of severe fetal anemia, and the prognosis. This is a cardiotography from a term pregnancy. The baseline heart rate, you see it is about 140. The variability is reduced, less than 5. No accelerations, and there are frequent deceleration. You see the deceleration is by more than 15 beats per minute, approaching 120 here, and the duration for more than 15 seconds. The decelerations occur after the contraction, so this is termed late deceleration. You see this is a contraction and the deceleration after which late deceleration. Here the contraction, and here the deceleration after the contraction. Reduced variability, as we mentioned that the variability should be at least 55 beats per minute. So here we have reduced variability less than 5, and here it is more reduced. Management of non-reassuring fetal heart status. First, non-surgical lateral position to avoid the compression of the vena cava and the aorta. The increase in cardiac output and uteroplacental perfusion will result from changing the maternal position. Oxygen by a face mask. Correction of dehydration. We give the patient intravenous fluid to improve the intravascular volume and uterine perfusion. Correction of maternal hypotension. Immediate infusion of crystalloid fluid. Stoppage of oxytocin. If the cause is excessive frequent contraction, then stop the oxytocin until the contraction subside, and then when the fetal heart is reassuring and absence of fetal anemia, oxytocin may be restarted. Tocolytics is given if the uterus is hypertonous and there is non-reassuring fetal blood sampling. You see here, we take a blood sample to measure the pH. The mother in left lateral position, an illuminated plastic cone is inserted through the dilated cervix against the fetal head. An incision 2 mm depth is made with a lancet. Blood is collected, 100 microliter, with a long capillary tube for pH and PCO2 estimation. Normal results when it is equal 7.25 and more. Borderline 7.21 to 7.25 indicate repeating the sampling after half an hour or 30 minutes with continuous fetal monitoring. And if it is equal 7.2 or less, this indicates that the fetus is acidotic. Thank you so much.